Welcome to the Glucose Never Lies podcast. I'm John Pemberton, a diabetes educator and researcher living with type 1 diabetes since 2008. I started the Glucose Never Lies website when my son tested positive for type 1 diabetes antibodies. In that moment, I realized I needed to build a resource strong enough to guide anyone who might care for him. At first, that meant writing clear, actionable management guides, but listening to Peter Attia's The Drive taught me something. Peter's conversations provide depth across nutrition, exercise, pharmacology, sleep, and much more. But I always find myself wondering, how does this information apply to people with type 1 diabetes? And this podcast is my attempt to fill that gap. I have access to the world's leading researchers and thought leaders in type 1 diabetes. That gives me a unique opportunity to combine lived experience, professional expertise, and cutting-edge science, and to share it all on here in conversation. But an important note, this podcast is for informational purposes only. These conversations share knowledge and experiences. They do not create a therapeutic relationship. So let's get started. And today we're joined by Peter Adolfsson from Sweden, who is basically a world-renowned doctor when it comes to paediatric care and medicine, has been heavily involved with ISPAD and certainly then exercise guidelines, and is essentially a thought leader when it comes to technology, type control, and essentially really helping young people with type 1 diabetes and their families. So welcome to the show.
Thank you.
But how I really met Peter was I was fortunate enough to present in Ireland. It must be nearly 5 years ago now. And I had an old crude exercise calculator that we were kind of building at the time where I was working. And Peter was extremely generous with his time and offers of advice to kind of say, look, you should really push this forward. And from there, he was the lead author on the ISPAD guidelines and invited me to come on, which I was very grateful for and learned a lot. So thank you for that.
Thanks.
But today, we really want to kind of, the people who watch this podcast are generally people with type 1 diabetes who are very interested in technology, and especially parents and children of young people want to kind of find out how you manage as a country, but specifically within your practice, to achieve such, I guess, in target HbA1cs, but not at the cost of quality of life. And then also thinking about timing tight range as you move on. So what I'd be interested to find out of you from a start is, how did you get interested in type 1 diabetes? How did your practice kind of develop? How did this kind of synergy come between technology and your interest?
Yeah, I think it was about me working as a pediatrician from the beginning. A nice fellow, Ragnar Hanås, my mentor, came towards me in clinic and said that, Peter, you are working as a sports medicine doctor. Yes, I said. And you know a lot about physiology and you like exercise. Yeah, I did. And you know a lot about diet and these stuff as well. Yes, some knowledge. You will be perfect in diabetes. And he brought me on. And this was when I actually did practice in order to get a license as a specialized doctor. And he brought me to conferences. At the start, we shared even his hotel room.
As you've got to do.
Yeah, and made it easy for me. And suddenly I was introduced in diabetes. But from the beginning, I've always asked myself this, because I have a passion for it. And I had two friends at school in the same classroom. One got diabetes when he was in grade 4, the other one in grade 8. The one in grade 4 has passed away, and the one in grade 8 got a son with diabetes who passed away last year. So I think I've always asked myself about the driver components in this, but I think that in a sense, this is the reality, and I have been blessed ever since, because the match between exercise and diabetes was perfect. It was rarely knowledge about exercise in the diabetes group of doctors, and it was rarely knowledge about real exercise. So it was a perfect fit from the beginning.
So obviously there was early experiences with your friends, and then obviously developed through with seeing one of your friends and having a son with type 1 and seeing the challenges that parents undertake, mixed in with your exercise physiology and I guess just a space opening up.
Yeah.
The benefits
Yeah.
of activity and exercise we just discussed previously with Othmar, the multiple benefits,
Yeah.
knowing that, and then seeing to fuse that in with type 1 diabetes. So
Yeah.
and then how did it come about that you was leading the ISPAD exercise guidelines in 2018 and 22?
Yeah, they even asked me before that,
Mhm.
and I thought that I was too young. I was too kind of
Use a few more grey
unexperienced.
hairs
Yeah,
before
yeah,
you were
yeah.
happy.
Now there are a few more, probably because of the guidelines.
Yes. Yeah.
But at that time, it was a learning process, more or less. Ken Robertson from Scotland did a really, really great job on the first one.
That's 2014,
yeah,
right?
yeah.
The first one.
Yeah. And then I entered 2018. I tried to shift the component of leading, because leading a guideline is quite hard job.
Mhm.
And it was a challenge to move backwards a bit in order to let the other ones get a space, not be the first one always to run and have them after you, rather to be the perfect team leader and push them forward in a way and let them go. And yeah, this was the case.
Because that's one thing I observed, because I wasn't involved in 2018. In 2022, I was involved, and very much I was, I guess, surprised and happy with how much kind of autonomy you was kind of giving yourself. Like, this is your area.
Yeah.
Like, John, you're with Othmar. This is
Yeah.
your area. Come back and bring something, which for me was great, because I was
Yeah.
like, oh, I'm not just sitting on the sidelines. I'm
No.
getting fully involved. And I know Desi, who's taken over this time, I
Yeah.
believe, and she did a phenomenal job at
Yeah.
pulling things together, working with you, and really give her the opportunity, a real taste what it's like. And now she gets to go this time, which is amazing.
It is. And it was a great team. And
Yeah.
I think that the second time I did it, more people on board actually working. So it was a great team effort.
Yeah, that's brilliant. Yeah, and some of the tools that we produced were fantastic. And so that kind of thing gives the audience a feel for your venture into type 1 diabetes, from early childhood to, I guess, exercise physiology, fusing that then in the guidelines. And obviously now, from anyone who I speak to who will be interested in sort of technology in type 1 diabetes, you're always the name that comes up. You're involved in writing advanced guides for how to use CGM for Dexcom. I remember seeing one of those. I was involved in an attempt in the UK to try and borrow some of that, and obviously involve you in terms of, well, CGM is not just a tool to look back and look at what someone's control is like. It's like, here's the information, what you're going to do for the future. So tell us a little bit about, in your clinic, how you teach people to use CGM and AID systems that maybe is different to what the average center would be.
Yeah, I think that from the beginning, I did like education as well. I was in the army for more than 2 years, and then taught to how to lead and taught to how to educate. So I brought this into practice. I even brought the component of being a team doctor from the national football team in Sweden. Some thoughts about how you actually guide a person. And then I realized that, there is not an adequate use of the systems. We could reach much further. And this is forward thinking. Well, what would be the next way to actually achieve better results, and that, this and that. And at the time we had sport camps in Sweden. We had 8 of them, and everyone attending the camp stated that, oh, Peter, CGM is perfect. And they wanted to go on the CGMs, which they used during the sport camp. And going back home from such a camp, one of the attendees asked me that, why don't you write something about this? And this was the first thinking about the Dexcom G4 guide. And then it was G5, then it was Libre, G6, G7, and so on. So what I do find important whenever we have national courses in pump technology or advanced courses in technology is that you have to educate the person using a tech device, whether it is a smart pen, a CGM device, or a pump. Then bring them back to clinic, probably initially to a nurse, 1 to 2 weeks afterwards, tweaking and looking for what is the target? Why should you have this device? And then actually creating like a target and then discussing how to reach the target. It can be about alert settings and so on. And then we added a number of revisits and everything. And when I brought this thought to the adult care, which I'm situated in now, I'm doing both pediatrics and adults. They said that, Peter, we can't do that. We can't bring them back so early because we don't have time for it. And I stated, then you shouldn't start, because it is as an investment. You need to plan for a structure regarding the start, frequent follow-up at the beginning, and now the adult facilities see that this pays off. We have done it in 2 years now, and this is the #1 clinic in 18 to 30-year-olds. So
that's really interesting, because I know in the UK, certainly, there is some centres that use structured education programs and some that don't. But it sounds like, and I think it's quite clear, that the investment that you put up front, especially with learning how to use the technology, coming back, there's obviously an element of self-learning, but sometimes that guided learning, or, well, when the arrows are pointing up, you could add an extra 10 or 20% insulin on. If the arrows are pointing down, this is the amount of carbohydrate you could consider based on the trend arrows. All those little things, getting some guidance up front helps you kind of learn as you go.
Yeah, and even some practical aspects, as you have provided. Do exercise after the peak, then you actually get a quicker response than adding insulin. Such tips and tricks. This is what we actually try to educate people about. And today we have had pump courses for more than 1,000 healthcare professionals. And we have had 33 advanced tech courses, national based in Sweden. More than 1,000 has attended these courses. So I think that one level is on the personal level, educating the person with diabetes, but it's also to remember that the healthcare professionals, they also need the guidance.
And I think that is a major challenge now, because I know where I work, at the beginning of 2023, we realized we had people coming onto AID systems of 4 different systems. And if we were honest, the healthcare professionals in the team, there was probably 2 of us who are pretty nerdy. And we would we would do the deep dive and we would know our stuff. But obviously that's 2 people out of 15. Which is not helpful for the people coming. So what we said is we applied to our charity and we put on our own AID study day where we went through the algorithms, we did case studies and whatever. And then you realize, okay, that's good for one center, but then there is, and that's maybe 300 kids, but we've got 20,000 kids with type 1 diabetes. What about the other 19,000? And I think that's where Sweden are a different level in terms of, if someone's doing something good, let's share it, let's roll it out nationally, let's make it happen. How as a country did you make that happen? Because it's sort of happening a little bit now in shared practice, but you guys have been ahead of the curve. What mix of people, or what made that happen?
Oh, this is interesting. We have, from the beginning, we have a national diabetes registry. Everyone is on board. Ever since early 2000, actually.
And how are they on board? Are they on board because they want to be, or because accountability has been driving that? Because that's, I think, for me, is like, accountability always makes the difference. And if there's like a carrot and a stick, it works really well together. If it's just a carrot, it never works. It has to be a carrot and a stick.
Yeah, it started with a carrot because the clinics didn't have to declare who was who. It was clinic A, B, C, D. And the man starting this, after a while, he had quite many clinics, because they found an interest in just comparing,
Mhm.
and they were asking him. We can see that Clinic F, they are good at the teenagers. Can you put us in contact with them? And when this started, he got the clearance from the government that this is a national registry.
Mhm.
Now you can open up with the names,
Oh, okay.
and now we are going to put the stick on. So suddenly everyone was forced
Mhm.
to join, and from that moment on, we have all clinics sending in from the beginning by paperwork, but now automatically.
Mhm.
So we have all the data on acute hypos, DKA, type of treatment, blood pressure, all complications, HbA1c, time in ranges over time. And what we then do, we continue to do this, try to learn from the skilled ones.
Mhm.
And for me, this is like competition in football.
Mhm.
Everyone looks at Barcelona or Real Madrid or in the past Man United, but
Yeah.
today Liverpool.
Yeah.
So this is the way it works in sports, and I was kind of surprised that in diabetes it was like professors or doctors trying to build their own tower in a way and not sharing. And I wondered why, because it's by doing this we actually become better. And Sweden was early on with tech,
Mhm.
I might say, with pumps from the beginning and then CDMs, increasing numbers from 2016. And I think it was about 2017, 18, we decided uh, we don't want to lie to the parents. We had put the CDM devices on healthy individuals
Mhm.
who didn't have diabetes, and we noted that 95% of the values were between 3.9 and 7.8. And this is when we started to use 3.9 to 7.8 as the measure or target
Okay.
range.
So that what year was that?
I think it was 2018.
Okay.
And then it was a sudden drop.
Right.
And we realized that this is all about nudging
Yeah.
in a way. You tell or ask someone that you should look at this instead of this.
Mhm.
And this was in reality created by a company in the United States.
Yeah.
Yeah, just to fit the majority.
Sure.
Yeah. So we noted that, and then we got some assistance even from UK later on, discussing 48 as
Yeah. HbA1c.
yeah,
Yeah.
it was
6.5%.
perfect because excellent job done.
Mhm.
It was easy to bring on that one instead of having 52, another drop. And then the centers attending like a quality program,
Mhm.
it was like a company.
Mhm.
You had to produce 1 to 3 targets during a year to have a person assigned to evaluate and then provide feedback to
Peer
the
reviews.
clinic and then provide feedback to the other clinics. And suddenly we learn from each other. They are focusing on the one that from the debut until 2 years. Let's do that because this is working. These one, they are great at pumps. Which pump are they using? I suddenly got phone calls coming up.
Okay.
So this is the aspect of teamwork in Sweden.
And it's interesting because when you say teamwork, you're
Yeah.
talking national team.
National.
And I
Yeah.
think that's maybe, I mean, I can give you the reflections from the UK. So obviously, we now have the NPDA data because of Sweden, essentially the national registry. And then very similarly, you can see the trajectories of the overall HbA1c. As soon as that started, it dropped. As soon as then, as you mentioned, the HbA1c target changes from it was originally 58, which is 7.5%, down to 52, 7%, down to 6.5. As soon as people understand where the target is, things start to drop naturally. And I guess it's kind of come to a point now, probably in Sweden is approaching there. Now we've got AID systems on full reimbursement in the UK, and at the last count, over 60% of their children people are on it. In our clinic, 95.
Yeah.
And we've seen the overall HbA1c went from 60, boom, we're down to sort of 55, 56. Yeah. And I appreciate for some places in the world and some centres that isn't the case, and that will happen when they're on AID systems. And I think it's been shown from an accountability perspective that really works. I guess that leads us on nicely to, you've just described, you've gone from time in range, which is 3.9 to 10 or 70 to 180 milligrams per deciliter, as trying to achieve 70% in there. Are you aiming for now in timing tight range, or is it now timing ting, timing normal glycemia? What's the terminology? I've heard timing tight range, I've heard timing normal glycemia.
Yeah, I heard today Batalino, he stated timing normal glycemia. Okay, so it's ting.
It's a ting thing.
Yeah. We'll see okay. If it's accepted.
Either way, it's 3.9 to 7.8 or 70 to 140 milligrams.
Yeah.
And the suggestion is trying to aim for 50% in there. Is that right?
We have used at least 50%. Tajay wants 55.
Okay.
So it's bold, and I think it works if you have a newly diagnosed 0 to 2 years with diabetes. This is where we actually aim at 42 if possible. Yeah. So we try to put in some investments or effort along with the family, with the newly diagnosed person with diabetes, because we know from the registry that if we do this during the first 2 years, it pays off on long distance afterwards.
So I'm going to put this into context for us. We did a C-peptide podcast, and this really makes me think, actually. So what we do know is in the first couple of years, people have residual insulin function, which you measure by C-peptide. So it makes absolute sense in that first year to 2 years, timing range target should be 80-85%, timing tight range or normal glycemia should be 55-60%, when the residual insulin production is really helping out, and obviously get them on the best technologies available, because we know that the earlier that you have more in target control, the lower the risk. And I think what is also important, which I think I hear you saying, is there also has to be some permission that when the C-peptide starts to go off, because the residual function starts to leave, we need to relax things, because otherwise it becomes overburdensome on the family. So then you drop down to 50% time in tight range, 70% time in range, potentially maybe a bit higher, I don't know, depending on which technologies. And then maybe there is even some legroom to people who've had diabetes for a lot longer, who've probably got very little C-peptide, who have much more challenges with diabetes. Maybe it needs to be a discussion around an individualized target, depending on their lifestyle and circumstances, because there's always the flip side, which I'm on the side of. But by the way, I personally manage my own diabetes as tight as possible and as hardcore. But I also understand some people just do not want to live their life like that. And we have to be careful to say, well, this is what would be best, but it might not be best for you. Your individual circumstances, your family life, your other social pressures, your everything. So I just think sometimes the listeners, they might hear this and go, oh, these two guys, all they're talking about is perfect glucose control. I think what we're saying is the data is pretty clear. The tighter the glucose control for the longer, the lower the risk of complications. That is undisputed.
Yeah. And then it's even the way that we have social workers and we have the psychologist, and I put them into practice whenever needed. And I know that some countries don't have access to this. So this is also one part of the success story. We have the access to those professionals. And we already know that having an HbA1c above 65, 70, you know that here we find the issues. But today with the tech, I love working with this group, because this is the tricky ones. And this is the one that I am supposed to put in my real hard effort in. So I use AID systems. If they don't like to bolus, I choose perhaps a product where I can tweak and where I can work with the system.
So more like a 780 with aggressive short active time, or a tandem with a really high basal and strong correction, something like that?
Yeah, something like that.
Okay.
Or even with the Chem APS, or probably one of the three I would use. And today I have persons who either forget or omit doses. They might do one dose a week. But if they then apply some dietitian rules, or apply to the circumstances that they have this problem, if I can have them to eat maximum 40 to 50 grams of carbohydrates and do this 4 times a day, if they can do that, I can actually use the system and I can provide an HbA1c somewhere between 49 and 54.
Yeah, I mean, compared to 65, 70 for a lifetime, that is massive.
Yeah, it's massive. So this is why I actually think that they shall actually have the best products early on.
Yeah, and I think that's I'm really glad you mentioned that we also have, we're fortunate to have a social worker and a youth worker. And we have and they were the first people when the AID systems came, where they came and said, look, please don't let it be like pump therapy. Don't let these people be the last people to get access.
Yeah.
And I think that's something that actually, I don't know if centers are listening or people with diabetes are listening. I think we've all in some ways been scarred by old pump therapy, because the risk of DKA was real and it was a problem, because if they were high, it was, they didn't check for ketones. But I think the thing with these systems for me is they actually start running target more. So they used to become accustomed to running target more. Therefore, when they go higher, they actually take action on these systems, whereas before they didn't. And I think people are so worried about putting people with high HbA1cs on the systems when it's the best thing for them. The data shows it, personal experience shows it.
Yeah, and one should remember that they have probably had diabetes for a while. They had received a slap in the face a few times more than the perfect guy. And for me, this is leaving a guy behind, which we are not supposed to do. These are the first one to actually get the product. We always keep track on how many percentages is about 70, for example. I don't want anyone to be above 70. And then the next step would be, I don't want anyone to be above 65.
Yeah.
And then trying to move this
we're just so for let's talk about HbA1c there, aren't we? Which is equivalent to kind of like 9, 8.5, and then down to 8.
Yeah. And when I hear this, expressed abroad, they say that this isn't possible. Well, it is. It is possible. The second thing is that in some countries, they might say that, well, we don't put them on this device before they are doing carb counting or before they are bolusing. And then I say that, well, this is the problem. They can't do math, or they forget the dosing. So it is like, do you have to prove yourself? So I always kind of ask the doctor or the nurse in these countries that, so if you would like to have a driver license when you are 18, you force them to drive a moped for 1 year. It is just stupid.
The reason why I'm laughing is because I used to work for Medtronic.
Yeah.
And I was a pump educator, and I remember when we were there, the part of the education process was you have to complete these Kaufman competencies. You have to get a score of this before you can progress onto pump therapy.
Yeah.
And I really hope it isn't the case, but I'm sure it is in some places that mindset remains for AID therapy, which means that people are going, oh, well, you can only go on these systems if you can carb count, if you can prove you can do this, you can do that. I mean, the reason why they're struggling is because for whatever circumstances within their life, diabetes is bloody hard to manage. It's non-stop, relentless. Let's make it easier for them. You now have a tool which is even proven for those people with the higher HbA1cs to be the most effective, the most cost effective.
Yeah.
And the barrier often can be the healthcare professional who's thinking, oh, it might be a bit risky. Take that risk. Worst that will happen is that they will have maybe a DKA event. Well, they'll have that anyway, because they wouldn't have taken their long-acting insulin. But the potential upside is so big.
Yeah.
It's worth that risk.
Yeah, and it has to be equal.
Yeah.
As well, whether you have this skin color or anything else.
Yeah.
It's awful to hear something else.
It's really interesting you say that, because I was involved in a lot of work within the UK, and you can actually see on the old pump therapy in CGM, and the disparity is quite different. And I remember I went and presented on the CGM Academy that we did at ISPAD, and I remember dancing on the dance floor, and Dr Adolfsson from Stanford, she came over and she was with Desi, and we were talking, and name dropping here, but it was just so funny, because I was giving it the big one, going, oh yeah, no, we did a CGM Academy. She said, have you looked at your onboarding in terms of ethnicity? I was like, oh no, we're equitable.
Yeah.
And then it left a thought in my mind, and I went back and checked the data, and we weren't. We were onboarding the white Caucasian. And so I looked at the data, and I emailed her. I said, you're absolutely right.
Yeah.
And without knowing, those subconscious biases, and it's not on purpose, those subconscious bias comes in because you think, oh, they might not do so well, or we don't want to overburden them. And actually we flipped it, and we were proactive and made sure we got our ratios according to how our clinic is. But it takes that first step of someone to go challenge you and go, you think you're doing equitable care, but are you really? Look at your data. What percent? We had 40% Caucasian in our cohort on AID therapy. 80% of those were on, and you look at that and it makes you cringe, but it's a lesson that you need to learn and be honest with yourself.
Yeah, I think so too. You have to be honest, and you have to, I would advise every clinic actually to check.
Yeah, check. Hold your hand up. And I've presented this data and gone back and we've shown it, said, but if we weren't honest and almost put our hand up and went, we're not doing this on purpose, it's just for whatever reasons, subconscious bias, we thought they might not do well, whatever, that's the case.
Yeah.
That's number one. Number two is, okay, what are you going to do about it?
Yeah.
Number two is, that means you've got to do harder work, because they're more difficult to engage generally to get them interested in the tech, because they've never been offered it.
Yeah. Create a focus group and just deliver the system to that group.
And lo and behold, they're achieving the exact same results as the white Caucasians on the AID therapy.
Yeah.
So now we have equitable care, we have equitable results, but it did take swallowing a bitter pill that before we weren't actually doing it. And you've got to be big enough to take that on the chin. Yeah. But you've got to ask the question first.
Yeah. Ask the question, dig in, and remember that this takes time to get the results and to do all these things. But step by step, I might say that, and we, I applaud any country, any clinic to just ask, as you are now, about what are you doing, how are you doing it, because whenever there in the future is a challenge with a new team coming up, a new nation coming up, this is when we know that we actually have won something, because then we have left thinking about just Sweden being the team. Well, we are a number of teams around the world.
Yeah, no, exactly. Yeah. I mean, every time you go, I'm thinking more 3, 4, 5 years ago, especially in the UK, because we were following your model, essentially. We were following this peer support, national learning. So every time you go, you'd be like, oh, look at them, their HbA1c is lower than ours.
Yeah, they hate us.
Well, it's not only that, but it's good to have that competition, because then, for example, our centre, I remember when I joined, we were about halfway in the league table, and now we're in the top 3. But we're not looking at England anymore. We're like, where are these guys? We're going chasing you guys now. We're going chasing Sweden.
That's good.
Yeah, that's it. You've got a bit of competition.
That's the meaning of it. Yeah.
So far we've covered, obviously, technology, the importance of getting as in control as is possible for you with your circumstances and your technology. And that would be different for everyone. Maybe tighter control in that first 2 years of diagnosis when the C-peptide is certainly remaining. Keep it as tight as you can, but don't punish yourself too much. Like I've had this conversation so many times with families. They come back to the first or second clinic and they're like, we're 95% in range. This is amazing. Like, it's brilliant.
Yeah.
And take it in, but don't expect this forever, because if you hold yourself to this standard forever, you might end up hating diabetes.
Yeah.
If you can keep at this level above 70, above 75, 80% in range, that is going to be good enough. You've got to balance it off with what it takes if you've still not got enough C-peptide. And I think that thing is so important. And actually, we've started testing a few C-peptides here and there, because it's almost like an empathy tool. If someone's down a C-peptide of 1 or 2, they've got a much more bigger challenge than someone with a C-peptide of 150. And the reason why I say that is I'm like a cheat type 1. I've still got a C-peptide of 120.
Yeah.
So for me, my overnight control is easy because I've got help out there. So I couldn't compare myself to someone who had diabetes from the age of 2 who's got no C-peptide, and it's much more challenging. I think sometimes it helps doctors and nurses realize that some people are trying bloody hard. They just don't have that little help that other people have.
But they should actually also have one thing when they go back home from the diabetes clinic. If they are achieving the target, like above 50%, I always ask them to celebrate. Yeah. What are you going to do now? And they have a question mark in the face. And I say that, well, you have to celebrate. This is a win. But I also find the win in the person who increases time in tight range from 30 to 32. So this is also the aspect of doing clinic, I think, that everyone shall leave the room as a winner, because they leave the clinic with a smile and they realize that the clinic want to do good. And this is where the teamwork starts with the person. So these are tips and tricks from sports, which I think that apply.
Small nudges. Positive reinforcement.
Positive, working together.
So if we're moving towards, which I think diabetes is towards, time in tight range or TING of 50%, and we know AID is kind of just about getting there at a push, where do you see the future coming in terms of technology developments, whether it's different newer insulins, whether it's different fully closed loop with different hormones, whether it's GLP-1s alongside small doses? Where do you see the next level of therapy? Because I guess the way that I see this, because I did a podcast with Viral Shah, is kind of AID is taking us to as close as insulin only on its own is going to take us, unless insulins get faster. But what are the kind of next add-ons in, do you feel, from pediatrics especially? Because obviously one thing for adults is another for pediatrics. Where do you think that next paradigm shift is going? Because AID has been a game changer. What's the next thing, do you think, on the horizon? You might not have an idea, I don't know.
I think that the AID systems, whenever we add the flavor of the popular word of machine learning or AI, this might improve a bit. I think that when the platform starts to communicate with both clinicians and persons on the personal level or the clinical level, addressing what they need to do or what they need to think about. When you have an application that, if you approve of the messages coming in, if you are motivated to have this brought on, you can have advice coming up much more frequently rather than every third month coming to clinic. So what I think would be the perfect thing is actually when we start working with the fact that we have CGM data brought on every day, 288 times a day. Why don't we use the data? Today we are fixed to a specific schedule in clinic. And I think that we need to leave that behind. But this is tech-driven. I think that we need the accurate sensors, we need smart pens, and we need AID systems. At the end of the day, we will personalize treatment with GLP-1s or GIPs, adding this, even SGLT2 inhibitors, along with insulin treatment, even in pediatrics. Because we really cut the high ones doing that. Or for a person with every psychiatric disorder, he might not feel the craving of, I can see a biscuit. You get rid of that. And this is also something that makes me using that therapy more among those who actually need it. And I have a different threshold in this population just because of that. So I think that we will start mixing therapies. I would like to see the platforms being more clever. At the end of the day, I really hope that we will even see non-invasive continuous glucose monitoring coming out.
What do you think? What do you think is going to be the avenue for that? You think like a wristwatch, or you think maybe optical sensors?
I know some things about this.
I'm digging into your entrepreneurship. It could be the first exclusive for the glucose nebulizer.
So I think that I hope that we will see this in type 2 segments as a start.
Okay.
I mean, maybe later on in type 1s if it continue to work well regarding accuracy, because we have to keep that in mind. But these are more the things I see on a 5-year horizon.
Yeah. So if I just summarize from there, because it's a lot to unpack there, there is a lot to be learned or a lot to be gained from these platforms that have all the data, making machine learning algorithms that give more real-time suggestions in terms of tweaks to settings to AID systems or whatever. And again, there's a safety net there in terms of clinician, person with diabetes, how you communicate. But yeah, if you get 4 or 5 updates in 3 months versus none, and it's done on a threshold basis of it, people with more than 4% time below range prioritize what the situation is there. People with less than 50% in range, kind of go there. You can do that easily, but you really, the way that machine learning AI is now, that's got to be implemented. You can't have humans like manually going through. It should be able to be sorted.
Yeah, I need to go inside and see who is moving in the wrong direction.
Yeah.
And then I can create a list on 10 individuals, going to the nurse and say that these 10, you need to get in contact with them this week because their glucose control has worsened. It can be about sick days. It can be about someone died in the family, a number of issues. But if we can do this interaction, communication in a supportive style, much quicker, more frequent for some than others.
Sure.
Why not just send a smile to those who are really doing good all the time? Why should they attend clinic? They can do it once a year.
You're testing the boundaries now. You've tested them. I don't disagree. I mean, there's families who come to us. When they come, they kind of like, you pat them on the back, they say, really well done. Great.
Easy.
But there's other families that you could do, and they only need to come once a year. And then you could do with other families to be seen 6-7 times a year. And I think that model, certainly in the UK, the reimbursement is basically you have to see the child 4 times to get 4 HbA1cs. You have to have 8 contacts. So it's like, well, that's suggesting that they've all grown up with 2 parents, had money, had the same social circumstances, therefore get the same care. That's not social justice. Like, social justice is more the people who got the most get the least, and the people who need the most get the most.
Yeah, and it's not personalized medicine.
Yeah.
No.
It's interesting. So we've got that, and then we've also then probably the adjunct therapies. And I'm definitely in agreement on the GLP-1 therapies, because after the podcast with Bral Shah and seeing the main thing that I see that I think is the hardest thing, and it breaks my heart sometimes, teenage boys and teenage girls who come in and they want to lose weight. They're on 1.2 units of insulin per kilogram. They reduce their calorie intake, so there's not much food going in from here. But because the high circulating levels of insulin, their fat stores are shut off from releasing fat. So they're starving from the outside, they're starving from the inside, and then they give up. And they just need to have a lower insulin dose, but they can't get there. And the thought of being able to add in a small dose of GLP-1 to reduce that insulin dose and give them a chance, I love it. It's a massive thing.
I love it, because this is what we do today. But I'm peculiar about the muscle mass. So whenever I see this, or having a person with a lot of craving for some different food, I always start with the dietitian. They need to have the explanation about proteins, for example. I always discuss strength training with this group, and I want to have them. I can do this in pediatrics soon in adults. I would like to have them on an impedance meter or a DEXA.
So actually measure what's going on.
Because I want to ensure that as much as possible of the muscle mass is still there. We are going to lose some if they are really obese, because they have less weight and less pressure on the thigh. But at the end of the day, I would like to create a situation together with a person where they have much less fat at the end of the day, 1 or 18 months afterwards. So and prove this, because seeing is believing in a way. Then they know that I actually succeeded. And now we have done this cases by cases, and we can see that, well, this structure works. And I really agree upon the fact where you talk about the total daily dose and so on, because they are left behind if we don't add the GLP-1.
Yeah, well, all they're going to do is keep pushing more insulin.
They can do whatever.
Yeah.
But they are losing the game if we don't bring on the GLP-1.
I mean, I couldn't agree more. There's so many young people who I see who they're fighting to get really in target glucose control, but when the insulin doses are getting to 1.2, 1.3 units per kilo, at what point does the improvement in glycemia become actually detrimental because it's being stored as fat? And you're thinking, but you don't really have any option, because you're trying to get them to reduce down, and they do reduce down the calorie intake when they're starving, and they can't release the fat stores, and they come back and they're like, I'm not losing weight, I'm starving, I'm miserable. And you're like, I've got nothing else for you, but really you do. You've got a GLP-1 that you want to use.
And when you have seen these persons coming back to clinic with a huge smile, you realize. You realize.
And I think that is kind of what I'm picking up from recent conversations. Like I said, I think diabetes management 1.0 of insulin only has taken us to 70% time in range and glycemic based treatment, which is great. 2.0 could be GLP-1, potentially SLG2 coming in, adjunct therapies to keep that total insulin dose down, as well as controlling the glucose level. It's an exciting time. It's kind of like we've kind of got there on 1.0. It's time to go 2.0, 3.0. And I think doctors such as yourself and some of the other leading clinicians in the area who are already doing these things, presenting those case studies on here, on international conferences, are going to go, well, look, it works.
Yeah. And never forget the dietitian.
Yeah. Oh, well.
No. It's obvious for some, but it's crucial.
Yeah, absolutely.
Yeah.
Well, I want to be respectful of your time. We have covered a lot of ground. We've covered a lot of ground around how to make national change in terms of technology, improvements in overall glycemia. We've covered how to thinking about managing exercise, consensus guidelines. We talked about the moving towards time in tight range. We've talked about if we're going to get there for a lot more people, what's it going to take? Maybe diabetes 2.0. Is there anything else that you want to discuss, or anything that just comes to your mind that you want for the listeners to really sort of take on board or think about with regards to diabetes management?
Oh, this was a hard question.
You might not have anything. We might have exhausted it, which is fine. But if there's any simple things that really work for you in clinic, that are very reproducible, what sort of things, your take homes to people? Because you've already said a lot. Number one, positive reinforcement is a huge thing.
I think that whenever I meet a person the first time, this was how they brought me into adult care. I was actually handing over a person with diabetes who I promised to go with him to the adult facility. And then they asked me, Peter, have you ever imagined to work with young adults? And this is something that I could even, have a saying to my colleagues, because they made me send in my CV, and they came back and they said that we have seen your CV now. We want you to work in clinic 2 days, but we want you as a coach for a full day every week for 4 hospitals. So now I'm coaching the adult teams on strategies, on how to do tech, how to introduce tech and everything. The oldest person I have in clinic is 94. Wow. I had a lady coming back who was 89, living in a home with assistants, and she asked, who is doing the settings? And I said, it's probably me. I have never had this glucose control before. And then I realized that this is also the impact of bringing knowledge from pediatric centers to adult centers. But it made me humble, because I have seen how hard my colleagues work with the adult ones. In Sweden, the pediatric clinic have 4 times larger resources.
Mm-hmm.
And this is also one part of the success story, I think. So 4 doctors, but 1 in adult care. So this means that they have to struggle harder. They have to be smarter. But I would like to see more pediatricians spending some time at an adult clinic and vice versa, because this is also when we start to create team strategies over the border, and not just complaining about what the other one is doing. So that would be something to take home.
Sharing that knowledge.
Sharing, yeah.
Well, I want to say thank you very much, first of all, for taking an hour to help people really think through what it takes to make change, thinking about targets moving forward, why they're important, and also opportunities, but also for the personal help you've helped with me on the ISPAD guidelines, the CGM accuracy stuff, and you're just a genuinely good bloke. So
and thank you, John. Thank you for your work. Yeah, thanks.
It's a wrap.
Super. This was fun. Yeah.